Welcome to NSG 323, Study Session 8, Hyperemesis Gravidarum. Introduction. It can be assumed that prior to getting pregnant, you probably imagined that when you woke up in the morning, you would be nauseous, throw up, and then carry on with your day. In reality, it does not always play out this way. Whoever decided to call it morning sickness was probably sleeping through the day, because this nausea doesn't discriminate between the morning, afternoon, or evening. The condition of hyperemesis gravidarum is characterized by severe nausea, vomiting, weight loss, and electrolyte disturbance. Dietary changes, rest, and antacids are used in treating mild cases. Staying in the hospital is often required in more severe cases so that intravenous line can be administered to the mother in order for her to receive nutrition as well as fluids. There is no clear explanation as to why nausea occurs during pregnancy, even though it is believed that hormonal changes are the cause. In general, the nausea is not so unbearable, and by mid-pregnancy, you should be relieved of it. Nevertheless, if your nausea and vomiting are excessive, a doctor should be consulted, as it may be hyperemesis gravidarum, a rare severe form of morning sickness that results in a poor intake of fluids and food, or the fetus being in need of food. Learning outcome. At the end of the study session, you will be able to define the term hyperemesis gravidarum, list the signs and symptoms of hyperemesis gravidarum, highlight the management of a woman in pregnancy. Definition of hyperemesis gravidarum. Hyperemesis gravidarum, HG, is a complication of pregnancy characterized by intractable nausea, vomiting, and dehydration, and is estimated to affect 0.5 to 2.0% of pregnant women. Malnutrition and other serious complications such as fluid or electrolyte imbalances may result. Hyperemesis is considered a rare complication of pregnancy, but because nausea and vomiting during pregnancy exist on a spectrum, it is often difficult to distinguish this condition from the more common form of nausea and vomiting experienced during pregnancy, known as morning sickness. Epidemiology. Vomiting is a common condition affecting about 50% of pregnant women, with another 25% suffering from nausea. However, the incidence of hyperemesis gravidarum is only 0.3 to 1.5% after preterm labor. Hyperemesis gravidarum is the second most common reason for hospital admission during the first half of pregnancy. Factors such as infection with Helicobacter pylori, a rise in thyroid hormone production, low age, low body mass index prior to pregnancy, multiple pregnancies, molar pregnancies, and a past history of hyperemesis gravidarum have been associated with the development of hyperemesis gravidarum. Hyperemesis gravidarum is a complication of pregnancy characterized by intractable nausea, vomiting, and dehydration, and is estimated to affect 0.5 to 2.0% of pregnant women. Signs and symptoms of hyperemesis gravidarum. When hyperemesis gravidarum is severe and or inadequately treated, it may result in loss of 5% or more of pre-pregnancy body weight, dehydration causing ketosis, and constipation. Nutritional disorders such as vitamin B1, thiamine deficiency, vitamin B6 deficiency, or vitamin B12 deficiency. Metabolic imbalances such as metabolic ketoacidosis or thyrotoxicosis. Physical and emotional stress of pregnancy on the body. Difficulty with activities of daily living. Symptoms can be aggravated by hunger, fatigue, prenatal vitamins, especially those containing iron, and diet. Some women with hyperemesis gravidarum lose as much as 10% of their body weight. Many sufferers of AG are extremely sensitive to odors in their environment. Certain smells may exacerbate symptoms. This is known as hyperolfaction. Cyanism or hypersalivation is another symptom experienced by some women suffering from HG. Hyperemesis gravidarum tends to begin somewhat earlier in the pregnancy and lasts significantly longer than morning sickness. While most women will experience near complete relief of morning sickness symptoms near the beginning of their second semester, some sufferers of AG will experience severe symptoms until they give birth to their baby, and sometimes even after giving birth. Causes. While there are numerous theories regarding the cause of HG, the cause remains controversial. It is thought that HG is due to a combination of factors which may vary between women and include genetic, body chemistry, and overall health. One factor is an adverse reaction to the hormonal changes of pregnancy, in particular, elevated levels of beta-human chorionic gonadotrophin. This theory would also explain why hyperemesis gravidarum is most frequently encountered in the first trimester, often around 8 to 12 weeks of gestation, as HG levels are highest at that time and decline afterward. Another postulated cause of HG is an increase in maternal levels of estrogen, decreasing intestinal motility and gastric emptying leading to nausea or vomiting. Diagnosis. Hyperemesis gravidarum is considered an exclusion. It can be associated with serious maternal and fetal morbidity, such as Winnick's encephalopathy, coagulopathy, peripheral neuropathy, fetal growth restriction, and even maternal and fetal death. Women experiencing hyperemesis gravidarum often are dehydrated and lose weight despite efforts to eat. The onset of the nausea and vomiting in hyperemesis gravidarum is typically before the 22nd week of pregnancy. Management of women in pregnancy. Investigations. Common investigations include blood urea nitrogen (BUN) and electrolytes, liver function test, urinalysis, and thyroid function test. Hematological investigations include hematocrit levels, which are usually raised hyperemesis gravidarum. An ultrasound scan may be needed to know gestational status and to exclude molar or partial molar pregnancy. Treatment. The type of treatment that is required depends on how ill a woman becomes. Possible treatments might include dry bland food and oral rehydration are first-line treatment. Due to the potential for severe dehydration and other complications, hyperemesis gravidarum is treated as an emergency. If conservative dietary measures fail, more extension treatments such as the use of antiemetic medications and intravenous rehydration may be required. If oral nutrition is insufficient, intravenous nutritional support may be needed. For women who require admission to the hospital, thrombophylactics such as thromboembolic stockings or low molecular weight heparin may be recommended. Treatment. 1. Intravenous fluids. IV hydration often includes supplementation of electrolytes, as persistent vomiting frequently leads to a deficiency. Likewise, supplementation for lost thiamine, vitamin B, must be considered to reduce the risk of Wernicke's encephalopathy. A and B vitamins are depleted within 2 weeks, so extended malnutrition indicates a need of evaluation and supplementation. In addition, mineral levels should be monitored and supplemented. Of particular concern are sodium and potassium. Dry bland food and oral rehydration are first-line treatments due to the potential for severe dehydration and other complications. Hyperemesis gravidarum is treated as an emergency. Home treatment is often less expensive than long-term and/or repeated hospital stays, so the clients and relations are advised on how to prevent and/or manage hyperemesis gravidarum at home. 2. Medications. A number of antiemetics are effective and safe in pregnancy, including pyridoxine, doxylamine, antihistamines such as diphenhydramine, and phenothiazines such as promethazine. With respect to effectiveness, it is unknown if one is superior to another. While pyridoxine, doxylamine, a combination of vitamin B6 and doxylamine, is effective in nausea and vomiting of pregnancy, some have questioned its effectiveness in hyperemesis gravidarum. Ondansetron, Zofran, may be beneficial. However, there are some concerns regarding an association with cleft palate, and there is little high-quality data. Metoclopramide is also used and relatively well tolerated. Complications. Pregnant woman. If hyperemesis gravidarum is inadequately treated, anemia, hyponatremia, Wernicke's encephalopathy, renal failure, central ponting, myelinolysis, coagulopathy, atrophy, mallory, Weis's tears, hypoglycemia, jaundice, malnutrition, pneumomediastinum, rhabdomyolysis, deconditioning, deep vein thrombosis, pulmonary embolism, splenic avulsion, or vasospasms of cerebral arteries are possible consequences. Depression is a common secondary complication of hyperemesis gravidarum, and emotional support can be beneficial. Infants. The effects of hyperemesis gravidarum on the fetus are mainly due to electrolyte imbalances caused by Hyperemesis gravidarum in mother. Infants of women with severe hyperemesis who gain less than 7 kg (15.4 IB) during pregnancy tend to be of lower birth weight, small for gestational age, and born before 37 weeks gestation. In contrast, infants of women with hyperemesis who have a pregnancy weight gain of more than 7 kg appear similar to infants from uncomplicated pregnancies. End of study session 8. Thanks for listening.